these are the objectives. We have no particular other lives to influence today. Okay, so I'm going to go into this a little bit more from the perspective of the position. What are some of the connections developing between the province, the South West LHIN, and primary care? From a primary care doc's point of view, first off, I want to say that, in my view, the LHIN is a good thing. I wouldn't have spent most of my life in meetings in London and then taken on this job if I didn't believe that. Some of the data you see in front of you comes from the London Chamber of Commerce when they're putting together their argument for why LHIN should be abandoned. And they changed their mind after looking at this. But basically, the LHINs in the province replaced 7 other regional offices and 16 district health councils. And in our own LHIN, we dropped the number of people in the office from 90 down to 32. So they took on accountability for healthcare in this region with less people. And I can tell you the people who are working in the LHIN are busy. There's lots going on and there's lots to stay ahead of, and it's very high level, so hard to move it forward. So they're working hard, less cost, and we've had improved outcomes. So you can say that we've had decreased wait times for MRI, CT, hip knee replacements, and cataract surgery. So these are effective organizations in my view. As a primary care doc, I think it's important to say. And although there's no official funding agreement between primary care and the South West LHIN, there's lots of action, lots of activity, and they have been really interested in having primary care involved from as early as I can remember. And again, I've spent a fair bit of time down there as one of the guys who was interested in it. Their blueprint, Vision for Healthcare 2022, sets out what we're trying to get to. And throughout the whole patient experience in that blueprint, primary care is heavily involved. And the ideal of a strong community care system is central to that vision. The Integrated Health Service Plan, we're just working on a new one, 2013 to 2016. Those are the 3-year plans that get us to the blueprint. That as well, I'm sure, will have a strong emphasis on an integrated, coordinated primary care system. Even without funding changes, if nothing happens with hub models and all that, the primary care is central to what the LHIN is trying to achieve with the system. Other examples of the South West LHIN and primary care having interaction, these are all good things. Many of you know the Partnerships for Health initiative, 2008-2011, where 73 practices were involved in improved diabetic care. That was facilitated by the South West LHIN, financed by the Ministry of Finance, and external reviews showed improvements in almost all care measures over the course of that project. And as someone who's involved in it, you know, we do a lot better job treating diabetic people, people with diabetes, now than we did before. So that was a certainly on-the-ground success facilitated by the LHIN. That is morphing into the Partnering for Quality initiative. I'll speak more about that in a bit. And that's something that people here can certainly be involved in, and we would encourage. E-referral, the primary care network that John Thomas and I are going to be speaking to shortly. Group of physicians from around the LHIN who try and make primary care coordinated with the system. They quickly said the referral system, GP to specialist, is just horrible. It doesn't work. We need to fix it. Southwest LHIN had actually already started to do that with the development of a new referral system for hip and knee joint replacement based on what they're doing in Champlain. So the system's already set up there. It's worked beautifully, decreased the number of referrals by something like 35%. Everybody was happier, specialists and GPs. So we're working with them and supporting them in that process. FHIR was alluded to. This is something that is an effortless way for family doctors to get information from hospitals, and when it connects to CSWOL, it'll be over 4 LHINs. So they're working very hard to get the information to your fingertips. But again, if you want to join on to FHIR, you should be speaking to us, because I think, Glenn, we're trying to increase the number of docs that are taking advantage of the system. If you work in a small emergency room, then you know about these other programs, the Hip Fracture Improvement Project Initiative, where secondary centers in our LHIN are taking more or less call to deal with hip fractures. And instead of sitting in the bed for 4 days before they get to your own secondary center, or having to send everybody to London, this has got people out of those beds and into the operating room within a day or so. Much better care, saving lives actually. And the One Number and Life for LHIN initiatives have really helped to streamline transport to get people to the right place if they have a serious illness from your small emergency room. And then they've also been very supportive of the primary care network. The primary care network is governed by family doctors, but is supported by the South West LHIN, by the OMA, by the Regional Cancer Program, and ICCAC. So it's a very sort of interesting organization that John will tell you about, but the LHIN has been part of that. And of course they hired me, which was probably the best thing they ever did. The province's approach to primary care at this point involves AQ&A, that is access, quality, and accountability. And when they talk about access, they're talking about open access. So, and many of you have heard about too many names, advanced access scheduling, 24-hour scheduling, patient choice scheduling. There's all sorts of names for it, and we'll go into that a little bit, but it's been shown to make it easier for people to get in, increase capacity in primary care, probably improves things like cancer screening rates, immunization updates. Great quality of care thing to do, and not just docs. We have a lot of people here who aren't physicians. Everybody can do this. If you're a social worker and a FIT, you can do advanced access scheduling. You may not be 24-hour wait time, it might be 2 weeks, but if your wait times are getting out of hand, this is a queuing theory from the business world that helps you get a handle on it. And we're encouraging physicians to roster patients via Healthcare Connect. Again, we'll talk more about what the primary care network's role in that is, but we're working with them to deal with that huge unattached patient population problem. And just some tips right now. We encourage everyone to book in, to think about booking in with Health Quality Ontario's Wave 5. So that you sign up in June, you start in September, and this basically gives you coaching for advanced access scheduling. Or there's a self-management way of doing it on the website as well. Or you can ask me or Vineet. See him, he's coming. There he is. To come and talk about it in the office, and you can just do it. And we ask everybody to take on one Healthcare Connect patient. We're trying to roster all of the patients with diabetes. That's just under 200 people in our LHIN. Advanced access scheduling, the beauty of it, your patients love it, your staff love it, but don't tell anyone. It works really well for the doc too, because he goes home earlier. The Partnering for Quality in Chronic Disease. This is the next step after Partnerships for Health. It's funded by the LHIN, whereas Partnerships for Health was funded by the Ministry of Finance, and basically involves these steps, or these pieces. We're trying to sustain the gains made by Partnerships for Health in those 73 practices. We're going to continue with some quality and e-health coaching services, and I think those are actually key to helping your team work better, to have those people come in and facilitate team building. They'll be hosting a number of learning collaboratives, supporting data collection, which again is one of the key things that drives quality improvement in high-functioning teams, having good data. They have a Quest for Quality website with a number of the tools, including patient self-management tools, and of course patient self-management is the key piece of this. And they want to spread it to vascular, so let's stop talking about diabetes, hypertension, congestive heart failure, ischemic heart disease, and let's just talk about vascular health, COPD, asthma, and out to more practices. So we're hoping this moves forward. It's something that people can look into to get help with quality improvements in their own team. And then accountability, which is the piece Mike started to allude to. How does primary care, with 800 docs in our LHIN, and they're all doing their own thing, how do we get that to be more of a system that we can fine tune to deal with the issues that are in that area and provide accountability? There's a graph of the ministry expenditures on healthcare. As you can see, the percentage of the provincial budget going towards healthcare, we're almost at the point where we just have one ministry, almost 50%. And it's increased by an average of double inflation basically over the last year. So healthcare costs are going up and up and up. And I certainly think, and the government thinks, that a strong primary care system will help drive this down, but there needs to be accountability for those dollars. Other driving force here is that we may be at the change right now between underserviced with respect to number of physicians and overserviced. So they increased medical enrollment quite a while ago, and more doctors are going to be out, and And maybe in 10 years, if you're not offering a high quality, accessible practice, then people will just go somewhere else because there is going to be a somewhere else to go to. We can see this now if you think about it. If you're a physician who has a hospital-based practice, so you're a cardiac surgeon, general surgeon, whatever, you have trouble getting a job now. And it can be difficult to find work because there's no place for you. You need to be able to hook into a place to go. And there are a bunch of guys out there now looking for jobs. We're not seeing it in the community yet, but it's quite possible that over the next 10 years that will happen. One of the advantages of having a South West LHIN-led primary care initiative is that we can tailor things to the issues in our LHIN. So I'm just going to show you a few quick examples. This is the readmission rate for diabetic patients in our LHIN in the last few years. The blue line on the right is 2010, and the line to the left is 2009. And you can see that the readmission rate went up. And so this is something that the LHIN could put out to primary care. So look, this seems to be an issue. Let's dive down and look at this a bit harder. Let's try and improve some of the care maybe that seems to be behind this and get that readmission rate down. This is modifiable risk factors. Basically, the dots on the left here are the province for smoking, drinking, physical activity, and fruit and vegetable consumption. Basically, we're about the same as the rest of the province, but that is something that, of course, primary care would be working on. Intermediate risk factors, diabetes, high blood pressure, obesity. Somehow the obesity graph didn't come. We're actually worse in our LHIN for obesity, and that is something that we could work on as a group of primary care. We mentioned, Mike mentioned CTAS levels. So CTAS 4 or 5, those are the non-urgent ones that could probably be seen somewhere else besides specifically the family doctor's office. This graph here shows you the CTAS levels for people who went to the Emerge in our LHIN for arthritis problems. The orange bar at the top and the big blue bar in the middle, those are CTAS 4 and 5, which means they really didn't need to be in Emerge. And it's something we could work on, again, as a group to get those levels down. On the right, you see the bars for the number of COPD hospitalizations in Ontario, and that's compared to the various district health units in our LHIN. And you can see that we have a lot of COPD admissions in the South West LHIN. And later in the day, we're going to be hearing from one of the family health teams in the Sound area about how they are doing a quality improvement initiative around COPD. Because obviously it's an issue for us more than around the province otherwise. Not necessarily that people are going to the hospital too much. When you look at the prevalence of COPD in our we have a lot of it. I'm not sure why that is, but we do. Again, the Ontario's line is the bar, and the blue lines are, well, actually the orange line is South West LHIN in general, the blue lines are the various health, district health areas. So we have a lot of COPD, we have a lot of COPD admissions. This is something we could work on, and we'll be hearing about that later in the day. CTAS 4-5, not quite as big a problem, but there's still a fair number of those visits in our LHIN. High blood pressure, CTAS 4-5, again, the blue and orange bars are showing visits that could be done elsewhere, and if we had more accessible primary care. By the way, I was on call till 8 o'clock this morning. The last person I saw had a sore throat for one day. And I said, I don't mean to be judgmental at all here, but and I'm doing a talk later on this. You came to Emerge with a sore throat, why didn't you go to the office? And she said, well, it's too hard to get an appointment. The interesting thing is, we don't do appointments for sore throats in our office. We have a nurse who does all that through medical directives. And it's actually, so it's something we've changed, but the community hasn't caught up to it. She would have been, and they do rapid strep tests as part of that, but you don't get an Emerge, so it's actually, it's better care if they went there in terms of testing as well. The other issue besides hubs is that now we're into a situation where there's different primary care models, and so we have haves and have-nots, I'll call them. So a lot of the people in this room are in the haves, that is primary care physicians, or nurse practitioners, with and without a team behind them, co-located. So it's easier for me with the family health team to do a quality care initiative than it would be for maybe the NEAT, who is not associated with a community health center or a family health team. And is part of the idea with creating hub models maybe to share the wealth, to share these resources? Is that a potential, that's part of the discussion today, is there a way of navigating the system, enter CCACs better for the people who aren't involved in teams so that the quality improvement initiatives can be done with everybody. And to just touch on this hub model before we give the floor to John, this is a graph. The dark purple are areas where there are high levels of patient enrollment. So FIGs, FOs, FINs, where people are enrolled in a physician. You can see that in the region of our LHIN, there's a lot of patient enrollment, which is a good sign there. Having enrollment helps you to do data management. You need to identify your panel of patients to be able to improve care. In the London area, down here, it's less so, which I found interesting. So the city has a little more trouble with people not being rostered to a physician. And then the orange dots are the family health teams, and the numbers inside are the sites to each family health team. And you can see they're scattered fairly equally around the LHIN, and the triangles are community health centers. Is there a way to share the wealth if we don't get more family health teams? Because I don't see them coming. Is there a way to share some of those resources so that patients not associated with those teams get better chronic disease management? Mike alluded to the ISIS suggestion to create hubs based on, what they did was they looked at referral patterns between primary care and specialists. Specialists tend to be attached to a hospital, so they were able, so that's a pretty stable relationship, so they're able to look at groups that seem to be working together. And in our LHIN, this is kind of what the model looks like. They're attached to hospitals. That doesn't mean the hospital has to be the running organization if you do a hub. Like you said, it could be a health center or a family health team. But you can start to see that there are groupings here of family health teams, CHCs, and primary care docs that kind of work together already. And just finally, those three initiatives the province is looking at, in my view, come together very nicely in the medical home model as put out by the College of Family Practitioners of Canada. Medical home model talks about accessibility, quality initiatives with teams, medical student education. So docs agree with this. The province is looking at the other way. It's really just a matter of bringing all of this together, and we're going to have a nice discussion about medical homes through the morning here with the entire College of Family Practice. I'm going to move it over to John Thomas. Tom Johns. John Thomas. First of all, are there any questions? Great. John is one of the physicians on the primary care network. He works in Lion's Head. And by way of introduction, he's going to talk about our primary care network. And I'm going to help a little bit. John is someone who's very brilliant. I'll just say that. He looks at things in a totally different way all the time. He comes up with these really good ideas. So it should be interesting. I told him to, he doesn't have to, this is a party line slide deck he's showing, but he's not party line at all. So it could be good. John,
How about now? So. How's that? Okay, so when Rob had asked if I was interested and available to do a talk, I had some concerns. I was a little bit worried that maybe my relative youth might undermine the primary care network, but he expertly and confidently reassured me that here's my obligatory disclosure slide. Obligatory plug for our area and my kid. I'm up on the Bruce Peninsula. For residents, come up and play, come up and work if you're interested. What is the primary care network? Okay, so what we are is an attempt to address the problem of a disconnect between care coordinators, whether that be cancer care, diabetic care, preventative care, and the folks who are often doing the groundwork, the delivery of that care, family doctors, nurse practitioners, etc. And get those people talking together more than they have been
this work? Including a number of different organizational things. We, as Rob has alluded to, we cover a wide geographic area ranging all the way up to Lion's Head, where I'm from, and even actually off the map up to Tobin. So what is this network business? The word network has become kind of ubiquitous these days to the point that it doesn't really have a meaning so much anymore, but the meaning is actually important. Yes, information is important, but information that your peers find relevant tends to be more important to you. So, I don't know if your office works anything like my office. We have a fully functional EMR that works perfectly adequately, but my paper inbox is still always overflowing with conference advertisements, drug warnings, drug discontinuations, et cetera, most of which gets promptly filed into the round folder very quickly. As far as information transfer is concerned, that is a wildly inefficient, low-yield system, and doesn't compare nearly as much to the 5-second interaction with the trusted peer in the corridor who points me in the direction of a clinical resource that I wasn't aware of previously. That's the kind of high-yield information transfer that the network is looking to plug into. We all have these networks. You perhaps haven't called them networks before, but the primary care network is our attempt to set up a larger network that starts to feed quality information into these different micro networks. So if you haven't heard of the primary care network before, then that is our failing. We haven't plugged into your network just yet. So as much as the primary care network has a meta goal of trying to explore and develop these networks, in order to do that, we've given ourselves some more concrete goals to try and work through, and as we do that, try and keep our system of communication. So we have 3 general themes that we're working on. You've already heard bits and pieces of this already. Those themes are access to care, effectiveness and quality of care, and continuous quality improvement. So as far as the first goal is concerned, access, we gave ourselves the goal of trying to have offered 100% of all the unattached diabetic patients in Ottawa. So the idea of this was to get in touch with our primary care providers and encourage them to get in contact with Healthcare Connect. Obviously, Healthcare Connect has some concerns for some providers. I was one of those guys. I have to say, as an experiment, I enrolled a few months ago. It was far less painful than I thought it was. And we ended up enrolling 30 patients within a month in a fairly painless way. Painless for me, Secretary of And anyway, in our LHIN, so we have ballpark 750 primary care providers and 200 unattached diabetics on Healthcare Connect's list. So to achieve that goal of 100%, what that means ballpark is that one in three of our primary care providers, if they took on a diabetic patient, that's all of them. So that doesn't seem like a huge task to undertake, but it actually ends up accomplishing a major goal. So a little bit more on Healthcare Connect. I guess just show of hands, have people heard of this? Do we know about Healthcare Connect? Fine, good. So for those who don't, it's administered by care connectors who are nurses who work with CCAC. Physicians have to register with the program in order to accept the unattached patients. For me, my part, that took 5 minutes on the phone, not a big deal. Granted, I was charged on caffeine, but I'm still down to it, very big deal. And I guess just by way of looking at who is on the Healthcare Connect roster, of the diabetics, still the vast majority is considered not to be complex and vulnerable. So if you're concerned that you're going to open the floodgates to get a small number of very, very high needs patients, that's not necessarily. If you look at the total number of complex, vulnerable, or sorry, total number of patients that they have, the vast majority are in fact not complex, vulnerable. So the process for Healthcare Connect, for those who don't know, once a patient is registered, they get a confirmation letter so that they know that they're in that system now. But they are encouraged to continue to search independently for their own doc. The care connectors will update their charts periodically so that they can appropriately refer to the best matched physician. And this system is actually working. They've attached 10,000 patients already in the Southwest. So they have a scoring methodology that I frankly don't know all the details to, but in order to get classified as complex vulnerable, their general health status is considered. They look at how many chronic diseases they have activity-limiting disability, mental health issues, and obesity. Now, as any primary care physician knows, that does not capture all of your complex vulnerable. And if you're sent a patient that after you have met them, interviewed them, etc., you disagree and you believe that they are complex vulnerable, that's no problem. You contact Healthcare Connect and you receive a different billing appropriately. So the process from our perspective is, as I mentioned, you register with Healthcare Connect and they attempt to get an understanding of what it is that you're looking for, what your special needs are, what your interests are, etc. They will refer you patients based on your catchment area, your accessibility issues, languages, specialist population, etc. And when they're ready to refer you patients, they contact you first. This is, at my team, the major concern was getting enrolled with Healthcare Connect removes control of who comes into your practice. I can tell you, it's anecdotal, but from my experience, this was not the case. Once that referral has been made, then the care connectors will contact the patients themselves and let them know what they are to do next, whether that means that they call the office for the first appointment or they wait for you to call. It's fairly straightforward for the patients to get connected, and they do their own medical assessment. We all know that there's lots of physician incentives for taking on new patients, but there are specifically incentives for taking on new patients from Healthcare Connect. And if you're interested in more information there, still can't hear. There are some handouts at the front here with more information. Okay, so the second concrete goal for our access goal was to look at a patient-centered central referral process for family physicians. When the primary care network started to talk about this, there was a number of issues identified and a number of things that we would like to see, that we identified as wanting to see in a central referral process. We wanted the referrals to contain a minimum information that was required by the college, a centralized booking agency, although while it has problems, the benefits tend to outweigh those concerns. A response within 2 weeks. That's a tough one. Now, I don't think any one of us expects to see an appointment within 2 weeks, but in my opinion, that might not be unreasonable to hear back about when an appointment would be. Also, there was an acknowledgement that referral for chronic disease management is a completely different animal than referring for any kind of acute management. And the information on the form is completely different. At any rate, what would this be? That's not going to happen. Anyway, so what I mean by that is we narrowed our focus. And for the time being, what is going to happen, what looks like we're working on right now, is trying to accomplish all of these things for a much more focused referral, as in we're talking about for endoscopies, for hip replacements. That's
That's good.
endoscopy in London and hip replacements. Okay, on to the second concrete goal, looking at effectiveness and quality of care. We're looking to improve the colonoscopy follow-up from FOBT positive patients from 60 to 80%. I find this number kind of shocking, but apparently this is where we're at. Moving it to 80% is my feeling a very reasonable goal to get to. Is everybody familiar with colon cancer check? Is everybody using that program? Our family health team only started using it a year and a half ago. And for those who are not using it, I really encourage you to get on board. It's frankly a lot easier for the docs, for the team. There's initial front-end loading of work that needs to be done to get the packages out. But once that's out, those patients, if you get them at 50 years old, for the most part, you're done with them as far as the screening is concerned. It's all, the loop is closed, and those folks are taken care of, except for following up on the positive FOBT. So this is a report that ideally we would be getting once a year. For those who don't know, the last time that this was, first time that this was tried to mail out, we had a postal strike. Some forms were lost, and now they're moving towards encouraging docs to go through the Ontario ND portal to get this kind of report and essentially identify these folks in the red who are positive and have not been seen in their follow-up. This is potentially a very big deal. This is an administrative workflow issue that you can largely take off your table and farm out to colon cancer check. Okay, and I think at that point, I'll tag in.
Thank you very much. Thank you very much, Sean. Sorry about the mic. I think I was doing that too. I'll stand close. Just so you know, the primary care network, we've had requests from almost every other LHIN asking for our terms of reference. So it's something that everybody else is sort of looking at. We're a bit of a leader here. I have to say I'm proud of it, and I think it works really well. I have spoken about the next two things already to some extent, so I'm going to just show you one slide here. But we are, as a group, encouraging people to get involved in continuous quality improvement. I think a lot of the people in this room have done that. And advanced access scheduling. Hard to measure how many practices actually do that. How many people here do that in their practice? Wow. Okay, that's excellent. So we're going to just show you one slide on that, and then we're going to move to the next item on the agenda. That's my favorite slide. Oh, two slides. One of the principles of advanced access scheduling is to max pack your visit. This is the opposite of only one problem per visit, please, which works for doctors but doesn't work for patients because you have 4 things. That's 4 appointments. I couldn't do that. So in my practice, and probably many of the practices here, if somebody comes in with a sore throat, then you check, do they need a pap smear? Do they need a cholesterol check? Do they have any other issues? By the way, I'm having some chest pain. You deal with everything. Everything that needs to be dealt with that day, you do that day. And don't look at it as if you are wasting too much time that day. Look at it as if you are saving time tomorrow. So it's better for the patient, and it's in the end it's better for you. Here's the slide I just wanted to show to explain this in case you haven't seen it, although it looks like we have a lot of converts here. On the top of this picture, you have all the work coming in, the demand, and on the bottom of the picture, you have all the work going out, the supply. In most practices, those are matched. So if you have a 4-week waiting list, or an 8-week waiting list, or a 22-week waiting list, it's matched. It's just that you have a bigger backlog. You have lots of people waiting, but unless your waiting list is going up every single day, it's matched. So this backlog, this is a pot in the middle, causes everybody a ton of work. And in fact, we work really hard in Canada to keep people out of the healthcare system. So there's a ton of work. Those people go to a merge, they phone in because they want pain pills because they can't get an appointment 3 weeks and they're in pain. They think maybe I should get a test first. The nurse comes up to you and says, can we do this or can we do that because this person's waiting for an appointment, or where should I put them? And there's all this activity going on. Whereas if you just saw the person, it'd all be done. So get rid of the backlog. That's the basic theory. And then, and it doesn't have to be 24 hours, but that's probably the best in terms of getting rid of the backlog and getting rid of this work. And by doing that, based on numbers from Alberta, and this unfortunately is not published, they just told me this, you probably save yourself about 14% of the clinic's workload per day. That's a lot, that's like an hour. And if you talk to people who do advanced access, that's what they'll say is, my life's so much easier, I go home earlier. I don't know why, because I'm seeing everybody when they need to be seen, and now things are simpler for me. So it's a great example of something that doesn't cost money, it's just a change in how you practice, and it makes everybody's life better, including your own.